incentive. So similarly, I'm going to do my cases as pearls. This is how I do a lot of my talks. They're just some clinical cases with a multiple choice question. I know we don't have an audience response system, but think in your mind what answer you'd be picking. I'll go through a few text slides and I'll follow each case with a clinical pearl. There's 5 of them in your syllabus. For the sake of time, we'll get through 4 of them today. So I have nothing to disclose. So the first case is a 32-year-old female who presents for an evaluation of diarrhea and abdominal pain that she's had for 5 years. She gets lower abdominal pain and bloating 1 to 2 times per week. On those days, she reports 3 to 5 loose stools, predominantly in the morning or after meals. Stools are non-bloody, non-greasy, and never nocturnal. Stooling brings relief of her pain. She denies weight loss, and her past medical history is unremarkable. She takes no medications. She has no family history of GI problems, and her exam is normal. So which of the following is the next best step? No further tests, just reassurance. A CBC and an IgA tissue transglutaminase antibody. Stool cultures. EGD with small bowel biopsies, or colonoscopy with random biopsies. So thinking in your mind, this is a patient who really, based on her clinical features, has a diagnosis of diarrhea predominant irritable bowel syndrome. So I've underlined some of the key things in her history. So she has diarrhea with pain. And so to really feel comfortable with the diagnosis of IBS, you have to have a component of pain. And really, you look at her history, she has no alarm features, she doesn't have nocturnal stools, no blood. And so you might say, well, why wouldn't reassurance alone be enough in someone with irritable bowel? And that is the case, but there is some minimal testing that needs to take place, and the guidelines would suggest the tests that I've listed here. So you really have to be comfortable diagnosing irritable bowel syndrome based on clinical diagnoses, because we can put these patients through a lot of testing for the workup of diarrhea, but we can do very little testing and feel very comfortable making this diagnosis. So first you have to start with making sure they have pain with altered bowel movements. Again, people who have diarrhea without any abdominal cramps or pain likely have something other than irritable bowel syndrome. Then you go through the checklist of alarm features. Is it new onset rather than something with chronicity? Are they a male who are less likely to have functional bowel disease? Age greater than 50 with new onset of altered bowel habits, blood in their stool, nocturnal stools, weight loss, and family history of cancer. If those are absent, then you go to limited testing. And again, you have to check a CBC because obviously if they're anemic, that's going to prompt a different workup. The guidelines recommend if someone has diarrhea predominant symptoms, you should check a tissue transglutaminase antibody, and they give you some wiggle room to check a sedimentation rate or C-reactive protein. Again, if those are negative, you can feel very comfortable coming to a conclusive diagnosis of irritable bowel syndrome. So this is a chart that I think all providers should have in their office. This will save you 10 minutes in your office visit with a patient when they're going through this eloquent description of what their bowels look like. You can simply put this chart on the wall and have them pick a number 1 to 7 of what their bowels look like. So they're either going to be hard and lumpy stools or loose and watery. So this helps you make the diagnosis. So if you look at this chart, if someone has more than 25% of their stools as loose or watery, meaning this type 6 or 7 stool, they have a diagnosis of diarrhea predominant irritable bowel syndrome. If there's someone who has hard or lumpy stools more than 25% of the bowel movements, they have irritable bowel syndrome, constipation predominant. If they have half of one and half another, they have the mixed type. And if they have less than 25% of either, they're kind of in this undifferentiated. It's hard to know how to categorize them. But the take-home point of this case is that diarrhea predominant irritable bowel syndrome is a diagnosis that can be made with little exclusionary testing other than a CBC and an IgA-based TTG in the absence of alarm symptoms. All right, next case is switching gears a bit here. This is a 38-year-old female who presents to an emergency room with recurrent abdominal pain, nausea, and bilious vomiting. 6 months ago, she had a Roux-en-Y gastric bypass for obesity. She's had 3 episodes in 1 month. Pain is crampy, periumbilical, and crescendos over 1 to 2 hours, and is relieved after vomiting undigested food and bilious fluid. During the past 2 episodes, her ER evaluation, including CBC, liver biochemistries, abdominal radiographs, right upper quadrant ultrasounds were all normal. She takes a multivitamin of iron and also takes thiamine, calcium, vitamin D, and B12, but no other medications. No other past medical history. Her gallbladder was not removed with the laparoscopic bypass. So which of the following is the most likely cause of her symptoms? Overeating, biliary colic, an internal hernia, stenosis of the gastric pouch, or a medication side effect. So you might say, why am I including a patient like this in a talk on women's health? Well, we know that bariatric surgery is the most common demographic of people getting bariatric surgery in this country are women in their mid to late 30s. So these are patients that you're going to see in your clinic for a number of years for follow-up, and you have to be aware of the complications that they're going to run into. This is a patient based on history who really has features of a bowel obstruction. She has a periumbilical crampy pain, relief of her pain when she vomits. She has undigested food and bilious fluid. And that bilious fluid is a clue here, and I'll show you some pictures that will help you understand. So we'll go through some of these complications. So I'm going to really talk about the anatomy of a Roux-en-Y bypass. I'm not going to talk about adjustable banding, but I think this is important because a lot of the testing that you're going to do on these patients is dependent on their anatomy, and you really have to be comfortable with the anatomy. So up here, let's see if I can get the pointer to work. Oops. All right. So you can see here the gastric pouch. Oh, it's very touchy. So I'll just tell you, you can follow it. So you see the gastric pouch up high. That's the gastrocardia that remains. Very small volume, 10 to 15 cc pouch in most patients. You can see the gastric remnant, which is really almost the entire stomach has been transected and is really out of the flow of food contents. What isn't shown here, and it's important to remember, is the bile ducts and pancreatic duct are in the same anatomical location that they always are, in the duodenum that's now been bypassed. That bypass part of the duodenum is called the biliopancreatic limb. So you still have all of your digestive enzymes coming through that limb. You can see here there's an anastomosis at the end of the biliopancreatic limb. That's the part of the small bowel that's now been brought up to that small gastric pouch. That part from the gastric pouch down to where those two limbs connect is called the roux limb. And then where that roux limb and that biliopancreatic limb come together and you have mixing of oral intake and digestive enzymes is called the common channel. So I'm just going to show you two different things for comparison here. On the left side is someone who has a fairly short roux limb, that section from the gastric pouch down to that where those two parts connect. So someone like that is going to have a lesser degree of malabsorption because they have a very long common channel where their food and digestive enzymes mix. However, on the right, you can see this person has a very long roux limb and a very short common channel. So this is a patient who's going to have significant malabsorption. They have a very short length of bowel where their food contents mix with digestive enzymes. So that's important to note in a setting of someone who might present with more profound weight loss than you'd expect for the surgery. So what are some of the early complications to be aware of? Most of these will go to your surgical colleagues, but if you cover these calls or the emergency room, you need to be familiar with this. So an anastomotic leak is something that you don't want to overlook. This is an early complication, and you can see that you have 4 various anastomotic points, and any one of those could cause leaking. The thing that's important is these patients may not have many clinical features whatsoever other than unexplained tachycardia. You really can't wait to rely on peritoneal findings because this is someone who's fresh post-operative. They're likely morbidly obese. Your exam, if you wait for exam findings, it's going to be far too late. The other thing to think about, and this could occur early or it could appear late, like in this case that I gave you, is something called an internal hernia. Now what happens is a lot of these procedures are done laparoscopically nowadays, so there's few adhesions, and we basically have taken bowel and relocated it in the abdomen. So what's happened and what these 3 brown arrows show you is we create mesenteric defects. And those defects allow bowel to telescope through, twist on itself, and cause a closed loop obstruction. So these patients can present with nausea and vomiting of bilious fluid. Now I'll go back and show you this picture just so you understand the importance of the bilious nature. If you look at this diagram, for someone with a Roux-en-Y bypass to vomit and have bile in their emesis, that bile would, if you didn't have an obstruction, would have to come down that biliopancreatic limb and go retrograde all the way up the roux limb. So it would be very unlikely. So in the case that I gave you, it suggests there's some obstruction of bowel at or below the level where that biliopancreatic limb comes in conjunction with the roux limb. So both of these things would require an operation, and if you have patients with any of these clinical features, The morbidity and mortality of a negative laparoscopy or laparotomy is clearly lower than the risk of missing these diagnoses. So marginal ulcer is another common complication. This is an ulcer right outside the gastric pouch at the beginning of the jejunum. This can cause what we call stomal stenosis, which is a stricture that forms there from chronic ulceration. We know, and as I gave you that was one of the options in the case. You can imagine if these people vomit, they vomit immediately right after eating because the food gets into this pouch and has nowhere to go. So they vomit immediately. You shouldn't see bile in that emesis. These is usually caused by NSAIDs, so you need to ask them about NSAID therapy, and another common culprit is smoking, so make sure to ask about that. Bleeding can occur at any site. Again, early on it could occur from the sites of anastomosis, but later on it could occur anywhere, just like any typical GI bleeding. And you want to think about that excluded stomach that's behind there, and the only way to really access it is through someone who has an expertise in advanced endoscopy. We usually need these balloon-assisted endoscopes to get back into that excluded stomach. And so after doing, let's say, a typical EGD to look in the gastric pouch in the beginning of a rouleau, you need to refer them to someone who can evaluate that excluded stomach if indicated. Now, what about biliary stone disease? That was another option presented to you. So this really poses an issue. We know that patients who rapidly lose weight form stones. So if someone goes into a bariatric surgery and they already have stones or features of biliary colic, they should take out their gallbladder. It's actually pretty mixed about whether surgeons take out normal gallbladders in patients who are undergoing the surgery. There's probably half of them that do, half that don't. These patients can still form stones, however, in their common bile duct, and that's a real issue after they've had a Roux-Y bypass. The reason that's an issue is a typical Roux limb is 100 to 150 centimeters, and our typical scope that we use for an ERCP is 124 centimeters. So you can imagine we can get down this Roux limb, but we can't even get into that biliopancreatic limb with the length of our scope. And so if basically if you have a patient who presents with features of right upper quadrant pain, they have elevated biliary liver tests, like a bilirubin and high AST-ALT combination, or they have dilated bile ducts, you really need to refer them to a place that either has interventional radiology to be able to percutaneously access the biliary tree, or a place that has advanced endoscopy where we can again access this through balloon-assisted endoscopy or a surgical gastroscopy through the stomach. All of these patients will, to some degree, get nutritional deficiencies unless you replace them. Uniformly, most of them will need iron. They all should be put on B12 empirically rather than waiting for them to deplete, calcium and vitamin D. And again, given the age demographic of many of these women, you should put them on extra folate if they're in their childbearing years. And similarly, these patients should be on thiamine at least for the first 6 months. There's a new term coined bariatric beriberi because there's been deaths reported in the early post-op cases of patients with Roux-Y because of thiamine deficiency, so something to think about. So the clinical pearl here are there are many potential structural, absorptive, and nutritional complications of bariatric surgery. And so knowledge of this anatomy is really essential to be able to effectively manage these patients. All right, third case, a 34-year-old female is referred for IBS who is 16 weeks pregnant. She's had diarrhea in her teens, which has resolved in her 20s and recurred early in pregnancy. 4 to 6 bowel movements daily with nocturnal stools, no abdominal pain. Takes a prenatal multivitamin, iron, and levothyroxine. Her pre-pregnancy BMI is 17 with 5 pounds of weight gain thus far. She conceived her baby with IVF. Her TSH is normal. So we'll say it's 3 for the sake of our last discussion. So which of the following is the next best step? Tissue transglutaminase IgA antibody, colonoscopy, begin scheduled loperamide, stool bacterial cultures, or begin nortriptyline. So give you some time to think on that. So this is a real patient that I had. And so the first kind of tip off in her history is she has this label of IBS. But again, I've already told you, this gal is not telling you she has any abdominal pain. So right away you should be thinking, this probably isn't IBS. Maybe she had that in the past, but something else is going on now. She also has nocturnal stools. Again, someone who has nocturnal stools has something other than irritable bowel syndrome, and that requires a workup. Now, the being on iron therapy may not be too much of a red flag because a lot of women in pregnancy may need that, but you might want to look at when was she deemed to be iron deficient. She already has this flavor of autoimmunity with thyroid disease. She has a low BMI and low weight gain in pregnancy, and she has a history of infertility. Lots of clues here that this lady has celiac screw. And so, just for the sake of a non-invasive approach during pregnancy, starting with a celiac serology, and if it's positive, you really could warrant putting her on a gluten-free diet, and at the end of her pregnancy, 24 weeks later, you could actually get a small bowel biopsy at that point, because we know it takes 6 to 12 months to normalize your small bowel, so you still can have that histologic baseline. So in terms of the manifestations of celiac disease, we're familiar with many of these. We all think of the young child with a failure to thrive, weight loss, short stature. I think it's important to note, though, when the star by the weight loss is that at least 10%, and my guess is we'll see that number climb with years, is that at least 10% of patients with celiac disease are obese. So you shouldn't exclude that diagnosis in your mind just because you have an overweight patient presenting for evaluation of other symptoms. The other thing is when you look at the GI symptoms, again, we're familiar with diarrhea and bloating, but at least 20% of patients with celiac disease have constipation as their predominant bowel habit, and they're presenting with one of the other extraintestinal manifestations. Here's a list that I think is really important to think about and consider in your population. We used to call these the atypical features of celiac disease, but we know these are becoming more and more common to the point that now if we see a patient presenting with these and we diagnose them with celiac, the new term is really non-classical celiac disease. So iron deficiency anemia is probably the most common one that we see, and you can see that data on the bottom, that the prevalence of celiac disease in someone with iron deficiency anemia, even in the absence of GI symptoms, is almost up to 10%. And if they have concomitant GI symptoms, it's probably as high as 15%. So if you're sending a patient for an upper or lower endoscopy for evaluation of iron deficiency, you should request that small bowel biopsies be obtained at that time. You can see lots of musculoskeletal abnormalities, osteopenia, osteomalacia related to calcium and vitamin D malabsorption. This can present to our neurologic colleagues with seizures, ataxia, neuropathy. Clearly, there's a link between infertility and miscarriages. We all think of the skin condition, the itchy rash on extensor surfaces, so that's a little bit easier to pick up, but it still can be misdiagnosed. And they may not present you with the full vesicles. They usually scratch them to the point that it's scarred scabs on their extensor surfaces. And then a whole host of other abnormalities, probably abnormal liver biochemistries, and mood disorders are the ones that we might see. So how to diagnose? The TTG-IgA is still the best screening test endorsed by the guidelines. They don't recommend checking an IgA level in all patients just because the prevalence of IgA deficiency is actually really quite low, even in patients with celiac disease. So only check it if you have a strong reason to. Gliadin antibodies have largely fallen out of favor because they have very poor sensitivity and specificity. But I just want to bring your attention to a whole new kind of generation of gliadin antibodies called deaminated gliadin antibodies. So those are now fairly universally available and have sensitivities and specificities as good as the TTG antibodies. So if you see that being checked, those are fairly reliable as making the diagnosis as well. So who do you biopsy? Well, everyone who has a positive serology should get a biopsy. And the reason for that is because you really want a baseline histology so that if they later present with recurrent or refractory symptoms, you know that the initial diagnosis was right. Because once you put them on the diet, you really change your diagnostic ability down the line. Anyone who has a negative serology but really have a strong clinical suspicion, they really should go for biopsies as well because these serologic tests are not perfect, and so you might be missing some patients. Again, anyone with iron deficiency anemia and then any other unexplained feature. So we know that the treatment is a lifelong strict gluten-free diet. Patients will always ask, well, how much wiggle room do I have? Really they shouldn't. They really should have a goal of being 100% compliant, which is tough. They need to avoid wheat, barley, and rye, and we also counsel them that the first year they should avoid oats because of cross-contamination, only entering them in a year later if they're doing well. So in terms of how you follow them, you should at least at baseline when you make the diagnosis, have them see a dietitian well-versed in this diet, have them do a bone density if they're an adult patient. You can see a whole host there of labs that we checking for vitamin and mineral levels at baseline. Then at 3 to 6 months, you should bring these patients back, see how they're doing clinically, and if they had an abnormal serologic study at baseline, check it at that 6-month visit. And then annually thereafter, again, bring them into the clinic, see how they're doing clinically, recheck any serologic studies that were positive, and I usually have these patients see a dietitian, usually on an annual basis for the first few years. I think we've all seen just the blossoming of gluten-free products coming on the market, so I think it's good for them to revisit because a dietitian, it really helps them open up their diet quite a bit. And then if they had any abnormal labs at baseline, obviously you're going to continue to follow those. And there's a suggestion that you should repeat the bone density 1 or 2 years later if it was abnormal at baseline. People always ask, do you need to repeat the biopsies in these patients? And for most patients, you really don't need to. However, if they were asymptomatic at presentation, you don't have a symptom to follow, if you have a serologic study to follow, that's enough. But if you don't have those things, you may need to rebiopsy. And obviously for the patient with recurrent or persistent symptoms, you might need to think about that. So the clinical pearl here is that celiac disease now commonly presents with these non-classical extraintestinal features. So heightened awareness of these features is really key to thinking about this diagnosis. All right, last case. A 28-year-old female presents with constipation for 5 years, reports one bowel movement every 5 to 7 days. She has to strain and has a sense of incomplete evacuation. She's had to digitalize on occasion to evacuate a stool. And if you don't know what that means, I'll explain. No blood in her stool. She had a significant tear with her vaginal delivery 6 years ago, requiring forceps delivery. No family history of colon cancer. Weight is stable. Exam is normal with the exception of paradoxical contraction of the external anal sphincter. And again, you might say, I have no clue how to detect that on exam. I'll go over that. So what's the most likely diagnosis? Is this irritable bowel syndrome, slow transit constipation, rectal prolapse, Hirschsprung's, or pelvic floor dysfunction? So this is a very, very common cause of referral for constipation that we see in our clinic. So this is someone who has clinical and exam features of pelvic floor dysfunction. This goes by several other terms. Dyssynergic defecation might be another one that you see this referred to. So this tends to be in someone who's had chronic constipation, and some of the historical things in this case can help you decipher this from constipation predominant irritable bowel syndrome. Again, I don't give you any features of pain, at least not that I reported here, which you'd still have to have in the IBS constipation predominant patient. But here's someone who has to, really strain to evacuate stool, and they have to use their fingers to basically help remove stool, either by putting them in the rectum, or many of these patients will put fingers in their vagina to push on their rectum externally to help evacuate stool. And then again, we'll talk about the exam findings that you might see with it. And for her chronic constipation and her past vaginal delivery with some trauma to it are likely the risk factors for her. So we'll start with, well, how do you define constipation? Back to this brilliant form, again, saves you 5 more minutes with this consultation, right? So in the past, we always used to use a number. If people didn't stool more than, if they had less than 3 stools a week, that helped you make the diagnosis. But now that's really changed. More recently, we define someone as having constipation if they have significant effort to defecate, and again, we look at the stool form and saying, anyone, if you can see with a type 1 or type stool form, probably has a history of constipation. Because we know these stool type 1 through 7 really correlates with bowel transit. So someone who has a type 1 or 2 bowel form here, their transit is obviously much slower than someone with a 6 or 7 stool form. So there's 3 types of constipation, and I think this might help you decipher, well, what patients need a specific workup. So there's those that have slow transit, and this is usually from some myopathy or neuropathy or other metabolic process. There's those with pelvic floor dysfunction, which we'll talk about more in a minute, but why this occurs is because these people have impaired abdominal, rectoanal, and pelvic floor muscle contraction. So they tend to have everything occurring almost paradoxically. And then you have those with constipation predominant IBS. And again, they really should have pain or discomfort as a key feature with their constipation, which this patient didn't have. So alarm features for constipation are really almost the same as alarm features for diarrhea. So I don't think there's really any that are different there. New onset, older patient, blood in their stool, family history. Those are all worrisome things. And those patients should have a colonoscopy for sure. In the rest of patients, you can start with some basic metabolic things, the CBC, calcium, thyroid, and fasting glucose. Like I mentioned, if they're over age 50 or they have worrisome features, They should also have a colonoscopy. And if they have features of pelvic floor dysfunction, which I'll talk about in a minute, then you need to do a few different things. One is basically anal rectum manometry with balloon expulsion. And this is a test that our physical therapists help coordinate. Basically, you put a balloon in these patients' rectum and you insufflate it with a certain amount of air or water to check for sensation, which is usually abnormal in these individuals. You can usually put oftentimes you could put a very large volume in the rectum before they even sense that they have anything there. Then what they do is they apply progressive weights to this balloon to see what it takes for that patient to evacuate stool. And for many of these, or the balloon, for many of these patients, they require more than 500 grams often of external weight before they can evacuate the balloon. These patients should also have colonic transit studies because they may have a combination of both pelvic floor with secondary transit abnormalities, and you can do that in a variety of mechanisms based on what you have available. So what are the features of pelvic floor dysfunction? Again, this is a diagnosis. Even though I'll send them all for the diagnostic testing, probably 80–90% of the time I make this diagnosis on the history and exam alone. So there's usually some risk factor, either a traumatic childbirth, vaginal delivery. A large number of these patients may have a history of sexual abuse, so something to ask about. They may just have a history of chronic constipation, and because of years of progressive straining, they've just lost the normal ability to contract and relax appropriately. And then anyone else with any other pelvic trauma. Again, excessive straining is usually reported. A lot of times, and you have to ask patients these questions, they're not going to voluntarily report this. They oftentimes will have to rock forward, backward, side to side on the toilet to help use accessory muscles to evacuate a stool. They'll often feel like once they've gone to the bathroom and had a bowel movement that there's a sense of either incomplete evacuation or the 2 stars mark the things that are probably the highest yields if you find them. They have this sense of anal rectal blockage, like something is still there blocking their output. And again, if they have to use fingers to help them evacuate stool, and again, you have to ask that, you'll never get someone hardly ever to report that voluntarily, that's very highly suggestive of this condition. So what do you do on exam? I think in medical school, we're just not really trained about a whole lot of things on rectal exam except, stick the finger in and out. But there's a whole lot that you can glean in terms of pelvic floor dysfunction from doing a few extra things. One is to just, before you even do anything, look at the perianal area and have them first rest at relaxation, then have them squeeze, and then have them relax again, and then have them bear down like they're passing a bowel movement. So you should see some normal, a few centimeters of descent when they do these maneuvers. You shouldn't see significant ballooning down into the rectum. You also shouldn't see, some patients with pelvic floor dysfunction, you'll see no change when they bear down or when they relax in terms of their descent of their perineum. The other thing is once you insert your finger, again, first have them relax, which I know is easier said than done. Then I usually have them squeeze, relax again, and then what you have them do is pretend to evacuate your finger like it's a bowel movement. And these patients will oftentimes have paradoxical movements. So when you tell them to bear down and evacuate your finger, many of them you'll feel their sphincter complex tighten around your finger, which again is opposite of what you should expect with evacuation. And then the last maneuver is paradoxical contraction of the puborectalis. And I'll show you a picture which I think helps illustrate this. So this is normal physiology. So if you look on the left at rest, all of us have quite an angle to our rectoanal angle. And that muscle sling you see there is the puborectalis. So at rest, that muscle for all of us is at a pretty tight contracted state, as are our sphincters. When we want to defecate, what happens is that puborectalis, you can see, relaxes, that rectoanal angle straightens, and our external sphincters relax. So that provides a straighter line for you to evacuate stool. In patients with pelvic floor dysfunction, however, they have the physiology not only of normal rest, but more exaggerated. So when they're trying to evacuate stool, their puborectalis actually contracts, as do their sphincters. So you can imagine you're actually worsening the obstruction. And so on exam, if you put your finger in, you can actually feel that puborectalis. And again, if you have them try to bear down to evacuate your finger, you'll feel that muscle sling actually tighten around your finger. So those can be some helpful exam things that are very highly suggestive. So if you find this, you need to, and you diagnose it based on the testing, you should refer them to a biofeedback program, oftentimes a 1 to 2 week program with physical therapists that give them electrical biofeedback based on their relaxation. We know that this therapy is helpful, and at 1 year out, at least after this therapy, they have increased spontaneous bowel movements, decrease of this paradoxical contraction, their colon transit times improve. The hard population and the ones we struggle with are those with concomitant prolapse. And the surgeons will always want you to try to fix the pelvic floor dysfunction first, because if they go to the operating room first and they haven't fixed the pelvic floor dysfunction, that strain will oftentimes tear any sutures or cause repeat prolapse. So the clinical pearl here is that constipation associated with a sense of anorectal blockage, the need for digitation to evacuate stool, and paradoxical contraction of the puborectalis is very highly suggestive of pelvic floor dysfunction, and anal rectal manometry is indicated. So we'll quit there. My email is at the end of the slides in the syllabus. I'm happy to take any emails for questions afterwards. I'll take questions at the podium here for the next 10 minutes.
So when you're looking at stool incontinence, is pelvic floor disorder one of your first diagnoses also?
No, not for incontinence. For incontinence, that's a whole nother workup. It could be that as the patient is aging, maybe this is just a primary, disorder causing diarrhea, and their sphincter complex have actually weakened with age, which can be a normal physiology, and the diarrhea can't, keep up with their weakened sphincter. The other thing is, have they had sphincter damage? And we know that that's probably